All right, everybody, welcome to Chest Injuries. And as you guys can see on our title slide here, everybody loves the gory drama of impaled objects to a chest cavity. While we're talking about this, there's going to be a significant amount of chest trauma that's involved in our chest injuries. And this can also be a chest injury that's not due to violence. So as we dig deeper into this, just try to understand that inside the thoracic cavity or the chest cavity, there's a lot of significant organs that are essential to survival. And so we really want you guys to be on top of your game when it comes to this type of an injury. So again, these are pretty common and they're potentially very serious. The damage to heart, lungs, and great vessels is very highly likely if we have any kind of injury to the thoracic cavity. The potential for internal bleeding and air collection, because this is an actual cavity, right? This is its own structure, is very likely, and it can be life-threatening. 1 in 4 trauma deaths is a result of a thoracic injury. So just a quick recap of what's going on here. You guys know where the diaphragm sits. It's along the lower section of the rib cage. We have both lungs. The heart sits in the center and slightly shifts to the left. And then we have the great vessels. And remember that this entire cavity contains things that are essential to simple survival. Without the lungs, for just a few minutes, we're going to go into cardiac arrest, and any kind of damage or trauma to the great vessels, and we're going to internally, maybe externally exsanguinate or bleed out. And if the heart is damaged, then we're not going to have the ability to pump any kind of blood. So if we're looking at the thorax, we're talking about what the structures are that make it up. And the long flat plate bone is the sternum, and these are connected to the ribs. As you can see, you've got the rib cage that runs up and all the way down. The jugular notch is where the clavicles meet the sternum. The xiphoid process is kind of that small triangular shaped thing at the base of the sternum that you can palpate on yourself. When we're talking about muscles of the thorax, these muscles help protect the underlying organs, and then they provide the necessary movement for breathing, and that's the diaphragm and the intercostal muscles. Then we get into the trachea, where it divides at the carina into the left and right main stem bronchi, which then again branch out into bronchioles and further and so forth until we get to the alveolar pockets. This is the only supply of air to the lungs so that we can have gas exchange for adequate perfusion. The lungs occupy the entire thoracic cavity except for the mediastinum, which is where the heart resides. The left lung has 2 lobes, and there's 3 on the right, and that's because the heart sits slightly shifted to the left, so there's a little bit less room, thereby the left lung having a little bit less surface area. It is surrounded again by that pleura, and this is so that we can have the lungs, which have that visceral pleura, and then the thoracic cavity has its pleura, and that's so that the lungs aren't dragging and causing friction as they inflate and deflate. There's a serous fluid, which is kind of lubricating those. The heart sits in its own pleura, right? That's the pericardium, which is that sac surrounding the heart at the base of the great vessels. And this is so that as it's beating, it can rub kind of against the lungs without actually causing friction. The heart, again, is also 4 chambers. We have the 2 atria and then the 2 ventricles. These are feeding into the great vessels, or are being fed by the great vessels and feeding the great vessels. And so this is the inferior and superior vena cava, the pulmonary artery, the pulmonary vein, and then the aorta. Now, the aorta branches into the right brachiocephalic artery, the left subclavian artery, and then the thoracic arteries, as well as the carotid arteries, and then the anterior and posterior intercostal arteries. That's a lot of fairly large arteries that are running right out of the heart, and this is feeding the main portion of the body and as well as the brain. So we've already talked about these other great vessels. Just know where they're kind of sitting in the body. The esophagus connects the pharynx with the stomach and the abdomen. That's that smooth muscle tissue that's running from the mouth to the stomach. The diaphragm is the barrier of the thoracic cavity into the abdominal cavity, and this is what is the primary control for any kind of respiratory pattern. If you guys remember that ventilation is the mechanical movement of gas in and out of the body, and that inhalation is an active movement. the diaphragm flexing, and then this pulls down towards the abdominal cavity, which reduces the pressure inside the thoracic cavity. And unlike what we're going to read on the slide, atmosphere pushes in, right? Because Mother Nature wants everything in balance. So when we have that reduced pressure inside the chest cavity, the atmosphere is going to force its way in, not something that you actively can feel. And then exhalation is passive. This is the weight of the chest actually falling back against the lungs. The diaphragm relaxes, and this causes increased pressure in the thoracic cavity, which forces the gas out of the body. When we're talking about spinal cord injuries where people lose the ability to breathe, that's at the level of C5 or below. When we're talking about spinal cord injuries, anything at C3 or above, that patient can lose the ability to breathe spontaneously. And if it's at C5 or below, they may have a reduced respiratory pattern, or I should say reduced respiratory ability, because they lose the ability to move intercostal muscles, but the diaphragm is still going to contract and relax normally. Chemical changes influence the rate and depth of breathing. That's your chemoreceptors, and this is measuring carbon dioxide in the blood. If you guys remember talking about the respiratory stuff, carbon dioxide levels create the want to take a breath in. Stretch reflexes tell us to stop breathing in, and then exhalation starts. As air enters the lungs and fills the alveoli, we have that gas exchange from diffusion. All these chapters are tying back together. And then carbon dioxide and waste products that can leave through gas exchange leave the body. Now we're going to get just a little bit back into respiratory alkalosis and then maybe acidosis. And this is the way that the body's controlling the respiratory pH. So that could be that, again, respiratory alkalosis or acidosis. Alkalosis is the result of hyperventilation. That means that we've exhaled too much carbon dioxide off and there's too much bicarbonate in the body. These patients will self-regulate. At a certain point, they will faint and their body will start breathing normally again. The only time that this is an issue is as a result of a massive TBI, where the brain stem is actually getting too much pressure and the internal regulation of the body for the respiratory pattern is kind of run amok. The respiratory acidosis is the inverse of the alkalosis. This means the patient is not breathing enough. Carbon dioxide levels are building because cellular metabolism is still happening. And at that point, the byproduct of metabolism, again, is that carbon dioxide. And so as it builds up in the bloodstream, it becomes respiratory and then metabolically acidotic. Without the heart pumping as normal, obviously we're going to have that reduced perfusion because we're not able to circulate oxygenated and nutrient-rich blood to the cells, and we can't get the waste products of metabolism back out and excreted in their appropriate locations. Quick recap on cardiac output, which is the volume of blood delivered to the body in 1 minute. Cardiac output equals heart rate times stroke volume. There's really no way for you to know what the stroke volume is in your patient. It's just something for you to understand that 1 minute is the unit of time that is measured for cardiac output, and that's due to heart rate and what we're actually getting in actual volume or blood flow. Okay, so now we're going to try to run through this a little bit quickly as far as pathophysiology and mechanisms of injury. And it looks like my slide probably got jumbled up here, but there's two main forms of mechanisms of injury. And as you can see, it says blunt, and underneath that it should say penetrating. This particular picture has this gentleman laying on the ground. He's bleeding from the thoracic cavity, so I'm going to say that's a penetrating injury instead of a blunt injury. Blunt trauma is anything where we have significant force, but it's not penetrating, it's not made its way through the skin or into the thoracic cavity, and this can be fractured ribs, sternum, and a chest wall. It may bruise the lungs and the heart, and again, we're not penetrating the external layer of the body. Blast injuries can be blunt or penetrating. They can actually even be internal from the pressure wave actually trying to equalize inside the lung tissue, causing a pneumo. Thoracic trauma can impair cardiac output. You guys have heard me say this before. If you have some kind of a pneumo or a hemopneumo or any kind of swelling or something like that, we're actually putting pressure on the lung. You can be collapsing the lung, crushing it, causing it the inability to actually diffuse gases and trade out oxygen for carbon dioxide, as well as that pressure pushing against the heart so that the heart now starts pushing against the vena cava, which is going to choke off the blood supply and cause further cardiac compromise. When you get into things like cardiac tamponade, that's where there's a small nick in a vessel or in the tissue of the heart, or say something has burst and we're bleeding into that sac around the heart, and every time the heart beats, it creates pressure, it puts fluid around the outside of the heart. And so for me to put this into like perspective for you, I want you to think about say somebody giving you a bear hug, and then every time you exhale they just squeeze a little bit tighter. Or you could even think of like a boa constrictor or something along those lines that's actually suffocating as the animal is exhaling. It just keeps constricting until they're unable to actually ventilate, and then at a certain point the cardiac output is going to go to zero. Pretty simple to go through the signs and symptoms of a chest injury. Pain at the injury site aggravated by breathing, right? This is somebody who has, say, like a dislocated or a fractured rib and they really don't want to breathe. They'll tell you it hurts to breathe, it hurts to breathe. They're dyspneic because they really need to breathe, so they're going to breathe shallow and rapidly, which is going to present like they're unable to get air. The hemoptys, which is where you get that pink frothy sputum, the saliva or the sputum is going to have a little blood tinging to it. Asymmetrical movement of the chest, that's that paradoxical chest movement. They take a breath in, the chest wall actually caves in. Rapid and weak pulse or a low blood pressure, and that's because we're getting that tamponade. And then cyanosis around the lips or the fingernail beds, and these are telltale signs of hypoperfusion, right? These are the initial, I'm not getting the right gas exchange. These present very quickly. After any kind of a chest injury, any change in the breathing is important. So we know that our adults breathe at 12 to 20 times a minute without any difficulty or pain. Patients with chest injuries are often going to have some kind of respiratory change where they're either breathing quickly or they're going to be breathing really slowly. And this is mostly due to what's causing them the least amount of pain. Changes in blood pressure can come with a variety of different things in regards to the extent of the injury. And so if they're bleeding into the chest cavity, they can become hypotensive. If it's just putting pressure against the vena cava, they can become hypotensive. So it's kind of hard to figure that out unless you're using breath sounds. Patients may present with hypothermia because they're going to start shunting, especially if the spinal cord is also involved in this, because anything significant enough to cause blunt trauma to the chest, it can also cause blunt trauma to the spinal tract. All of these signs and symptoms can happen at the exact same time. It's best to not get caught up into the game of I'm going to figure out everything that's going on with a diagnosis, and instead we should be focusing on how to manage their vital signs and get them to the appropriate facility as quickly as possible. Anytime you guys are dealing with chest trauma, you should automatically wonder if there's any kind of violence involved in this, so ensure that you have a safe scene, follow your standard precaution, and then make sure that by standard precautions you're also covering yourself up. PPEs, we want gloves, we want probably some kind of mask and a face shield, because if this patient has a chest injury, there is a likelihood that there's going to be blood coming out with exhalation, or they could be spitting blood, and we don't want any of that bodily fluid getting into anything on us that's a mucous membrane or a break in the skin. Triage your patients, understand who's viable, who's not, who needs to go now, and who has a little bit more time. And then always request as many additional resources as you can, because again, if you guys remember, if you think about a red patient, right, the triage tag red, that person is actively trying to die, and you need all hands on deck to mitigate that problem. If you've mitigated that problem, they would be degraded down to a yellow. In your MOI, NOI, you're always looking for indicators of significance, and this is pretty easy to come up with. If you have a significant chest injury and it's blunt, that was a high mechanism. That's high force, high volume. Do we have any other additional patients? Is this a single patient? What was the cause of this accident? And what is the likelihood that we have multiple patients? And then again, considering spinal immobilization, the new current practice is to only see collar patients and then get them on the gurney into the trauma suite. So when we're looking at this picture, you see this particular female here, and her external jugular is sticking out. And this is just kind of a graphic representation of what distended jugular veins would look like. And in the event of distended jugular veins with somebody who's not put into a flexion position like this, this patient or a patient with distended jugular veins means that the heart is being pushed against the vena cava and blood is pooling up on the right side. So you know that this patient is unable to actually continue to prime the pump, and you should be looking at that as a sign of what's going on inside the chest. Transport decision. I can't say it enough. It's always do your quick rapid trauma sweep, CAB or ABC, depending on what the mechanism is, and then we're going to get them going. This is a rapid transport. We don't have time to play with these patients on scene. This is not appropriate for the most part with almost any patient, but a patient with a real chest injury is a fragile patient, and so you want to get them moving as quickly as possible. So on this slide it says immediate life-threatening chest injuries must be detected and managed. For the most part, there's only a couple of these that you can actually manage. The AEMT is not able to manage cardiac tamponade. You can manage flail chest. You cannot manage massive hemothorax. You can't manage tension pneumothorax. You can manage a little bit of an open pneumothorax with a occlusive dressing. An esophageal injury is nothing that you're able to actually do. Diaphragm, nothing that you can do. Bronchial disruption, nothing that you can do. You can change the airway obstruction if you can get to it without having to intubate. So don't get caught up in this, I have to do something other than transport your patient and try to manage their airway the best you can without causing any more damage. Your physical examinations as far as secondary assessment should be done en route. This slide says may need to be performed en route. It needs to be done en route. If you have somebody with a massive chest injury, they are in harm's way. You need to get them to the appropriate place. So do your secondary while you're getting to where you need to go. Look for your injuries and then try to prioritize anything that's going to compromise your ABCs. So if it's going to compromise the airway, that's something we have to fix right now. If it's going to compromise breathing, we have to fix that if we can right now. And if it's compromising circulation, we need to fix that as quickly as possible as well. By what we're talking about here, just being chest injuries, there should be evidence of trauma. If not, then we're probably looking at a spontaneous pneumo. And so it's kind of a misnomer on the slide. But trauma affecting multiple body systems may have distracting injuries. So do your decap BTLS, look for your major bleeds, stop the bleeds, figure out if you got holes, cover the holes, and then get them going on. Obviously, we're going to have a full set of vital signs because we want to see if our patient's trending up, maintaining, or trending down. And then be aware, is the pulse rate becoming accelerated? Is the blood pressure slowing or lowering? And then, or are we showing a slowed pulse and respiratory rate? And are we getting ready to go into like an arrest situation? Your pulse oximeter should be able to tell you a lot about what's going on with oxygenation. And I'd like to make sure that anytime you have something going on with significant respiratory problems, we should be on end tidal CO2. We want that end tidal because it's going to give us a waveform and a value. It's going to tell us how the lung function is working and if the gas exchange is appropriate. So we're going to get into a couple of specific managements for different types of injuries. And in this first one, this is rib fractures. Pretty infrequent in children. The rib cage is fairly pliable, but as we get older or the elderly, if they have some kind of osteoporosis or something like that, or just their bone density is degraded because of age, they are susceptible to rib fractures. Injury to the upper four ribs is a very serious sign of severe MOI, and that's because there's so much muscle and things to protect those ribs that if we see those broken or there's like a significant part of trauma to that, we know something bad came with it. Morbidity and mortality increases with age, the number of fractures and the location of fractures, and this again mostly has to do with the fact that as we get older, we have the inability to actually heal and rebound very well, and we're not able to compensate, and we have any kind of trauma like this to the chest, it is significant. Obviously, a fractured rib can lacerate a lung. For the most part, when we have fractured ribs, they tend to kind of float with the rest of the rib cage, and you'll see a little bit of movement. But this is potential to cause a pneumo. If it tears and it actually causes a bleed, we can have a tension pneumo or a hemo or a hemopneumo, and this can get really kind of out of hand quickly. One of your big signs for this is that you don't have like an open chest wound, but as you're palpating, you have that subcutaneous emphysema. And that sensation, again, the only way for me to describe that is that kind of Rice Krispies sound or feeling underneath the skin as you palpate. that means that you have gas leaking out of the pleural space underneath the skin. The skin is now the new kind of barrier for it to stay inside the body. If you have an injury to the floating ribs, this also suggests a severe MOI because they are only connected to the spinal tract in the back, and because they're not fixed very greatly, they have a little bit more latitude to flex before they break. So regardless of the position, any rib fracture puts the patient at risk for multiple injuries. Again, if we get a rib that's kind of floating around in space and it can get its way dug into, say, the diaphragm or into the pleural space or even the lung tissue, we have a problem. So if you guys remember me talking about the flail chest earlier, or that paradoxical movement, this is where we have multiple fractures and a section of rib cage is moving independent of the rest of the rib cage. And this will kind of look a little odd to you because as the patient takes a breath in, you're going to see something depress from the negative pressure or the reduced pressure actually pulling suction on those now free-floating ribs. In this slide, it says mortality rates increased 20 to 40% because of the mechanism of injury and how significant the trauma must have been. The detachment of the segments from the chest wall is what creates that paradoxical motion. Again, when you're looking at it, the patient's going to take a breath in. You're going to see a section of ribs kind of depress and make a little bit of a pocket.